So with that, I will turn it over to Christine McMullan from Stony Brook University Medical Center.
Thank you, Wendy. Next slide, please. Just to give you some background information, Stony Brook University Hospital is located on the east end of Long Island. We're the only tertiary care hospital located in Suffolk County, and we're a teaching hospital physically linked to the State University of New York at Stony Brook School of Medicine, as well as 4 other graduate professional schools. Next slide, please. Our journey for decreasing central line infections actually began back in the fall of 2004 when we joined the IHI, or the Institute for Healthcare Improvement, Critical Care Collaborative. And the collaborative incorporated the use of the central line and ventilator-associated pneumonia prevention bundles, as well as multidisciplinary rounding and daily goal sheets to improve patient outcomes. And we incorporated, actually, the review of daily necessity of the central line into the daily goal sheet, which helped to really have the team evaluate whether or not the patient continued to meet that line. We also created a centralized standard insertion kit, which included all the bundle elements that were needed for insertion. Next slide, please. So we did that for a number of years, and we saw our rates decrease, but they were not where we felt that they should be. So we really took a look at our resident education, and when we surveyed our different services, we found that each one of them really had their own credentialing criteria for credentialing new residents in the insertion of central line. So expanding on the standardization concept, we decided to create one standard protocol and credentialing program for our residents to make sure that they were all receiving the same information and they were all following through on the same step for insertion of the central line. And at this point in time, we actually did that mid-2007. So now all residents are expected to review an educational module, achieve a passing grade of 80%, demonstrate in the educational module, demonstrate competency in central line insertion on a simulator prior to in the patient, and at bedside prior to credentialing. Next slide, please. And just to tell you, it really, initially we were a little apprehensive because we thought that this program would cost a lot of money, but we found that you don't have to reinvent the wheel, or you can steal shamelessly. What we did is we found out about Duke's educational module, and we decided instead of creating one ourselves, we would actually lease theirs, which we continue to do at this day. We also identified one of the best practices for the insertion or the competency of insertion of central lines as Henry Ford Health Systems. And we asked them for a copy of their competency checklist, and we modified it for our personal use. So really, if you could learn from other best practices at other hospitals and then really take them back to your hospital and adapt them for your own personal use, it really is the way to go. Next slide, please. So we continued to see a reduction in central line infections, but we still were not happy with the outcome. And we decided to do a root cause analysis for every infection that occurred. And after further review of this data, we realized many of our lines became infected after day 7 of insertion. And when we started to dig down, we realized that the line maintenance process was not really where it needed to be. Our nursing staff were not accessing the lines using the same level of sterile technique as our physicians during insertion. So as a result, a central line maintenance protocol was developed and deployed in our ICUs. And now I'm going to turn it over to Dr. William Greene, who's our Chief Quality Officer. He's going to review the outcome of the data.
Thanks, Chris. On this slide, I will just call to your attention that this consists of the adult intensive care units, which in our institution includes separate units for the coronary intensive care unit, cardiothoracic, medical, and surgical. The baseline period, you can see this is a month-by-month graph. The rate is expressed traditionally as per 1,000 central line days, as in this. And you can see that between the baseline period, which we established over the course of 06 to actually 06, the 12-month, and 07, the 12-month mean of improvement was 83.4%. Next slide. Here are our pediatric results, again, per 1,000 central line days. The current 12-month mean shows a 72% improvement over the 2007 baseline period. Next slide. Early on, we saw very good compliance with the central line insertion bundle, but this was preceded from 2006 by multiple developmental efforts towards putting together a central line insertion cart, which had all the components to it, a central line insertion bundle audit sheet that was put together that was filled out by the nurses in conjunction with the physicians, as well as the resident training program that Chris McMullan previously described, which included the full gowning and so forth for the central line insertion bundle. So the earlier portion of this slide would have shown significantly decreased compliance with these various elements. But for the past 5 years, we've had very good compliance. Next slide. Here's a somewhat different expression in terms of per 100 patient months for central line associated bloodstream infections. And you can see that in the coronary intensive care unit, for the past 3 years, we've had essentially no central line infections, though the rate was low to begin with. And there's been very dramatic decreases in the other intensive care units. And one thing that I should call attention to is that we did initiate this effort on pediatric hematology oncology, which is not an intensive care unit, but obviously uses central line infections extensively. There was a sort of chaos of management of these infections, and when this was regularized, there was a very substantial decrease in central line infections on that service. Next slide. This is a kind of summary slide for the institution as a whole. And as you can see, we've had a 59% decrease in central line infections for the 2008 to 2010 period compared to the baseline in 2007. If you look off to the right-hand portion of the slide, you'll see that our most recent decrease over the past approximately year, most recent year, which coincided with extensive deployment of the central line maintenance bundle, has really come down to a substantially lower average than for the preceding periods. We've estimated that we've decreased 1,144 patient days with an estimated $7.5 million cost savings for the 3-year period. And this was making use of a Johns Hopkins website estimator for central line infections. Next slide. So in conclusion, the interdisciplinary team collaboration obviously impacted patient outcomes and decreased length of stay and costs. One thing I would add is that it was very important to make it clear who had individual unit responsibility in each of the units, both at the physician and nursing level, so that there was leadership, responsibility, and identification. Obviously, minimization and variation around best practices ensures consistent application of those practices in the insertion and maintenance of central lines. And we obviously need to continually reevaluate the barriers so as to move from sort of status quo to the next level, as we did when we evaluated resident education and then subsequently the central line maintenance bundle.